In my city, Boston, Massachusetts, and New England, they're within about a 2-mile radius. You can actually have a 30-year life expectancy gap from 60 to 92 between Back Bay and Roxbury neighborhoods, right? And so the context in which sort of talking is that, there was just in the sort of one of the preeminent science journals, Nature, this week, another article really saying that contrary to what many of us have been taught over the years, genetics is not, predominantly the main determiner, right, of how one lives in terms of health and well-being and illness. Much more really about social conditions. And so I'm going to talk a little bit about the responsibility and the role that healthcare institutions in particular play, which is in many ways probably a smaller part of the larger story, right? We think about these larger structures, the way our societies are designed, that differentiates these things. But I'm going to talk a little bit about an example from our hospital, Brigham and Women's in Boston, Massachusetts. And I think, an approach, what we'll call a repair-based approach or a reparative approach, that I think could be utilized at broader scale. And I'll talk about some examples there. So just over 22 years ago now, there was a report published called Unequal Treatment from the Institute of Medicine in the United States. And the New York Times had this to say about it. A disturbing new study by the Institute of Medicine has concluded that when members of minority groups have the same incomes, insurance coverage, medical conditions as whites, they receive notably poorer care. Biases, prejudices, and negative racial stereotypes, the panel concludes, may be misleading doctors and other health professionals, right? So really a systematic recognition of this problem, right? This wasn't a few actors here and there. This was something that we're noticing systematically in the data. What's more disturbing than this report from 22 years ago is that, an updated look at some of these inequalities and inequities, and particularly the ones that are driven by differential treatment in healthcare settings, haven't changed that much. Right. So while in the meantime, these last 2 decades, there's been a massive response in the United States to quality and safety concerns with a huge quality and safety movement, after a similar report was published on that topic, very little has changed in terms of racial inequities. So why, right? In Boston, there are a number of hospitals, a couple of which are associated with Harvard Medical School, right? And people, though, local folks in Boston have less access, right? And so in this Spotlight series from the Boston Globe a few years ago, they particularly named, a number of different hospitals, including mine, and talked about the distrust that communities of color, particularly Black, folks in Boston, have towards these institutions that have historically, locked them out or made them feel unwelcome, right? And there's one patient in particular, Shirley Coffey, who's highlighted in this article, who talks about that distrust of the institution, that growing up, despite just being a mile or two away, she never went to Brigham and Women's until much later in life. And she was in the emergency room waiting and really just felt uncomfortable and left despite not having her condition treated, right? So the perpetuation of this differential treatment and these inequities creates this vicious cycle in which communities don't trust right care, and that just makes it worse, right? Because of course trust and trustworthiness of these institutions is the basis for any kind of healing relationship. And so what I'm going to talk about is in particular an intervention, an approach that we've developed that is designed not only to fix some of the inequities that we're finding, but also hopefully to try to mitigate some of that trustworthiness problem that we have as an institution. Because again, if you can't rebuild or build that trust in the first place, you can't have that healing relationship. So a little bit of just a quick case study from our hospital. We have two areas of the hospital. It's two separate buildings, actually, and I'll show you the difference between them. This is our general medicine tower. It also houses a number of other patient groups, but towards the top are our general medicine patients. Any patient who comes in with a diagnosis of heart failure can go either to this tower and see a hospitalist like myself on general medicine, or they can go to our specialty cardiology center, which is much newer, has private rooms as opposed to shared rooms, and has other sort of amenities and nice aspects for families. insert specialty care from physicians and specialty trained nurses, et cetera, right? So historically, right, about 2/3 of our patients end up admitted here when they have heart failure in a cardiovascular center, and about a third end up here in general medicine, right? And we decided to look into this, right? For those of us who I was in my training years as a resident, I worked on both services. Whereas now, as an attending physician, typically you only work on one or the other once you're, a senior physician. But as a resident, we were working on both and noticing that the patient group on both was not the same, right? It wasn't a random assortment, was our impression between those 2/3 who go to cardiology and 1/3 who go to general medicine. And sure enough, we were right. We looked into the data. We looked at 10 years of data, and we found that about 2/3 of white patients would go to the cardiology ward, whereas only 53% of Black and Hispanic patients were admitted to cardiology. So significant difference. And even when we controlled for other factors that are influenced, if not determined, by structural racism, like were they already plugged into care? What type of heart failure did they have? What neighborhood do they live in? Poverty indexes, we still found a difference, right, for all patients who were coming in. So we were treating people differently on top of the structural and social determinant challenges that they were facing, is that we were accountable and responsible for some of this inequity. And it mattered, right? It wasn't just a question of separate but equal, even though segregation, of course, would be problematic and even illegal. It was also that patients who had cardiology were more likely to get cardiology follow-up. They were less likely to be readmitted. Not in our study because it wasn't sort of large enough or long enough, but in other studies, it's also shown to have a mortality benefit to be seen by a specialist. Okay, so it mattered, right? It really mattered that we were treating people differently in terms of outcomes. We did a follow-up study as well, and we found after surveying providers that the perception of providers is that white patients advocated for the cardiology care more often and more strenuously. And providers, predominantly white providers at our institution, admitted that they were responsive, right, to these requests, right, and they were more likely to also call outpatient providers for white patients than for patients of color. So at least some of this was being driven by, again, this was all sort of implicitly, this was a study we did and we only surveyed providers, but at least some of it due to those kind of biases. So when we then tried to think about what an appropriate approach to fixing this would be, right, we tried to look into examples in the literature. What have other folks done that have worked, right? We didn't find much, right? Looking in the health literature, we didn't find much. What we had already stumbled on, though, is a framework called Public Health Critical Race Practice that's been developed by Chandra Ford and Collins Arambua, which really takes a critical race theory-based approach to health inequities in terms of studying them and ultimately acting on them. As you can see here, I won't go through the whole model, but the fourth key focus area is that action. You need to, if you're going to be studying these kind of inequities, you need to have in mind already what you're going to do about it. How are you going to build an intervention? So we wanted to build this intervention. We just didn't know how, and we didn't have there was no data. Unlike so many other things, there really just wasn't data for how to fix a kind of problem like this. I'm going to do a little bit of a detour to talk through some of the dynamics of the challenges of how to sort of think through what's an appropriate response, right? So we want our care to be equal, regardless of people's background, or regardless of the race, ethnicity, religion, et cetera, right? But fixing such a problem is not so straightforward, right? And I'll talk about why. Nancy Krieger, the social epidemiologist and the developer of ecosocial theory, talks about the two mistakes you can make when interrogating race in terms of data, in terms of collecting data. And then she talks about the point of the sword being what we're going for. That's data for health justice. This same framework, I think, works really well for thinking about interventions, right? There's two key mistakes you can make when you're trying to develop an intervention to deal with racial inequities in health as they develop, right? So edge number one, again, she's talking about data, but this applies as well to interventions, is that, no data, no problem, right? So this means, like, if you're not disaggregating data by race and ethnicities, which many jurisdictions in the United States still are not, right? In many parts of the world, we don't know whether people are getting differential care because we're not tracking it, right? That creates, you're not going to find a problem if you're not collecting the data. This, of course, is a problem. That's one way you get cut. That's one edge you get cut on if you're not even able to look at this, right? Number two is that if your data is problematic, if you're misunderstanding what race is and what racism is in health, then this can also lead to a misleading element. And I'll talk about that as well. And then finally, we'll talk about sort of, I guess a responsible way to really approach, thinking about race and racism when it comes to interventions, right? So the first edge you get cut on, ignoring race altogether, right? So as Stuart Hall, the great social theorist and sociologist, British, Jamaican-born British sociologist, as he famously said, right, race is the modality in which class is lived, right? So race and class, rather than being sort of distinct entities or one or having a relationship in which one is subsumed into the other. They're interlinked, but they're still distinct and separate, but they're clearly interlinked, right? And so race being the modality in which class is lived, he later said also class is the modality in which race is lived, right? So these things are clearly linked, and we know that that both from data that both race and class are associated with health outcomes, right? Because of these human hierarchies that are socially created, right? Not biologically meaningful or genetically meaningful, but socially created. What's one of the big problems of ignoring race when it comes to outcomes, right? So if you have a problem that's differentially impacting people by race or ethnicity, right? So an example of institutional racism like ours, if you develop a solution or an intervention that is race blind or race neutral and it impacts everyone equally, you're not going to fix that problem in many cases, right? Because the people who are most able to take advantage of any new intervention are those who are already experiencing systemic advantage in society. And so oftentimes, even the best laid plans, when they are ignoring race and racism and how that's functioning, can end up even further exacerbating or at least not fixing the inequity that originally happened, right? So you can see here in this title, Disparate Impact, how colorblind policies exacerbate health inequities, right? So instead of taking an equity-based approach, you take an equality-based approach, treat everyone the same in your intervention, and sometimes that actually can worsen outcomes, paradoxically, right? Or not, right? Hopefully that makes sense and is clear. Second edge you get cut on this sword, right, by this metaphor is misunderstanding or misusing race, right? So we often talk about how race is socially constructed, and that's really important insight, but it only takes us so far, right? When we say socially constructed, we have to think about the historical processes that actually construct and change racial formation or racialization, right? And as historian Patrick Wolf says, races can be understood as traces of history because racialization acts to reflect, justify, and reproduce into the present the hierarchies that are engendered by these historical processes of colonization and domination, right? So all of these historical processes in which hierarchies were formed are driving and continue to drive racialization processes. This is what we were ultimately talking about when we say race is socially constructed. Ruth Wilson Gilmore, the geographer, has another insight that I think is very helpful here. So she says racism is the ordinary means through which dehumanization achieves ideological normality, the idea that people's lives are worth different amounts because of who they are, while at the same time, the practice of dehumanizing people produces racial categories. And so it's this vicious cycle, right? It's sort of, it feeds into itself as a sort of trap, essentializing people based on their socially perceived race, that people, this idea that race is somehow natural or normalized, right, as opposed to socially and historically constructed. A really additional important insight that Gilmore has about racism is that it's the state-sanctioned or extra-legal production and exploitation of group-differentiated vulnerability, premature death. What does that mean, right? That's what we talked about at the very beginning. When you have these dramatic life expectancy differences within societies, right? Gilmore is saying that this is the manifestation of racism, right? The ultimate manifestation is how societies create group-differentiated vulnerability to death, right? This shows it more dramatically than anything else, right? That's how racism sort of plays out, right? And so that's where life expectancy can be particularly helpful. What does that look like? Here's an example from COVID in the United States. You can see the graph here on the right. Interestingly, right, Latino or Hispanic Americans before COVID lived longer than white Americans. You can see in the gray line. You can see Black Americans in the orange line, shorter. But look at both Hispanic and Black Americans drop off in life expectancy in response to COVID compared to white, right? And that's that group associated premature vulnerability to death that Gilmore talks about. Even though Hispanic patients lived longer, and the reasons for that are sort of complex and won't talk about it. But when COVID came, they were much more exposed due to a number of reasons, right? Job exposure, right? Unable to work from home, so more exposure to COVID, poverty, living in more crowded conditions, all sorts of social elements that predisposed to premature death at a much higher rate, even though their baseline life expectancy was longer. And so, again, I think this graph with that dotted line drop off in response to COVID is a particularly powerful way of seeing how that plays out in the real world in terms of health outcomes and life expectancy. This graph also highlights that point from Stuart Hall, which is that it's both race and class. It's not one or the other. You can't subsume them. So here you can see men on the left, women on the right, and they're differentiated by both, you can see on the x-axis, by both race, so Hispanic, Black, and white. But then in terms of the bars internally, they're differentiated on a rough sort of categorization of class based on education. And you can see both elements, right? So if you see, uh, for example, looking at, women, having less COVID mortality than men overall, but huge differences by education and class, and also huge differences by race and ethnicity. So really, COVID again is sort of being that very clear manifestation about how some of these things play out because it happened in a very short period of time in terms of clarifying those vulnerabilities. So in terms of getting back to really thinking about that second edge, right? So one of the ways of problematically understanding race or racism is this idea of racial essentialism that I was mentioning. It's the belief that socially constructed categories reflect inherent biological differences, right? Which is not borne out by data or by historical reckonings. And this is implicit and explicit in the medical education that physicians receive, right, on both sides of the ocean, right, in terms of the UK and the US. This is unfortunately a big problem as it has crept in because the medical establishment historically was deeply involved in scientific racism and eugenics, right, and that still has trickled into the education system, seen in a number of algorithms that are used and a number of different approaches to health inequities. But this is really, it's an intellectual failing as well as a moral failing because racial essentialism attempts to utilize an oppressive sociopolitical fabrication or social construction, race, to understand genetic diversity and population ancestry or distribution of alleles, right? So it's a very problematic understanding. It has real world consequences in terms of the kind of biases that show up in care, right? If, and this has been shown in studies, if you believe that race is an essential or biologically based characteristic, this often leads to reduced empathy, right, among physicians, as opposed to a structural competency that understands these inequities and these social conditions as derived from historical and ongoing injustices. Okay. So what's the right way forward then, right? You can cut yourself on either of those two edges. So the third way forward is to use race and understandings of racism for health justice, how to stay on that point, right? And these three terms to me kind of both all sort of signify the same things. They're different terms for what I think is probably most readily approached as equity, which is that because of these historical and structural injustices, our approaches to interventions, right, shouldn't be sort of equally spread around the population, right? They need to be targeted in ways that meaningfully respond to those injustices and those historical patterns, right, for where the need is now most situated, for reasons that are unfair, right, that were societally determined, not determined by groups or people or individual peoples, right? And so I think the sort of most morally compelling argument is to then take an equity-based approach to these kind of injustices, which have deep historical underpinnings, certainly in the U.S. We came up with a model, which I'll talk about and put it out there, and this was in 2021 in this paper called An Anti-Racist Agenda for Medicine. really talking about the failure of a lot of what race blind or colorblind approaches, and instead thinking about repair-based race conscious approaches. And why repair, right? And again, I alluded to this at the beginning with the discussion of trust. And actually, I don't love the terminology of distrust or mistrust because it kind of puts the onus on the people, in that broken trust relationship as opposed to the institution, right? And so that's why I think trustworthiness or a lack of trustworthiness is much more accurate and important for framing, because distrust sort of suggests, oh, maybe, they're have conspiratorial mindset or something else, but it's actually based on very good reason, right, for mistreatment or differential treatment, right? So it's a trustworthiness problem in the institutions. And oftentimes that's really just not recognized by the institutions themselves or their representatives and health providers, right? We take it for granted, but you can see here these statistics from the Commonwealth Fund, and this was in a poll in 2020, 7 of 10 Black Americans say they're treated unfairly by the health system, and 55% say they distrust it, right? That's a very natural response to being treated unfairly, right? And the data backs that up. That's not just a subjective experience. But the ramifications are really manifold. So people who say they mistrust health organizations are less likely to take medical advice or keep appointments or fill prescriptions, right? So that broken trust, the trustworthiness problem, means that people are not able to get the care that they need. And they're more likely to report that they're in poor health as well. So the implication, so a repair-based approach is trying to get at this problem about trustworthiness as much as it is about fixing these kind of inequities that are in this system. So the approach that we developed, Dr. Michelle Morse and I, was what we've called Healing ARC. And we borrowed this acronym ARC from scholars of reparations. So Sandy Darity and Kirsten Mullen are sort of leading scholars of the movement for federal reparations for the Black descendants of enslaved people in the United States. And they take this acknowledgement, redress, and closure framework, which we said, you know what? Health institutions that also have this trustworthiness problem because of histories of differential care could also adopt this type of approach, right? Acknowledging, redressing, and working towards closure. So acknowledging is when the institution voices ownership and responsibility for the inequities. Redress is really the compensatory step, and I'll talk about what we're doing now to address the differential care for heart failure patients. And finally, working towards closure with community representatives, right? And this is an important point that I haven't brought up yet, which is the problem, right, was that our institution and providers in our institution are responsible for. The idea that we should then be the ones who come up with the solutions is deeply problematic, as opposed to the impacted community members themselves, right? That is an important piece that I think is crucial to understand, is that impacted community members, in our case, Black and Hispanic folks in Boston, need to be directly consulted to address this. This was our feeling, and one of the things we really wanted to bring into this work. So for the redress component, we worked on the language of this with what we're calling our community wisdom councils. So these are Black and brown folks in Boston, many of whom are active in health justice networks, but also other sort of social determinants networks of abolition or gentrification and other issues in Boston. And so what happens now, if you're a provider and you try to admit a Black or Hispanic patient to general medicine, you'll get this pop-up that says your patient's from a racial or ethnic group with historically inequitable access to the Brigham cardiology service. Consider changing this admission, right? And so it's, they can still click out of it. And we wanted to make sure we didn't create a new inequity by sort of very rigidly overriding any provider ability to determine what's best for the patient. But ultimately, we've been collecting this data for now almost 2 years. And what we found is about 80% of our 10-year inequity we've now redressed, right? So now about half, right? Whereas usually these kind of pop-ups in medical care only work about 6 to 7% of the time because providers often ignore them. Ours has been effective 50% of the time. So for 50% of Black or Hispanic patients where they tried to admit them to general medicine, they are now getting admitted to cardiology, right? So this kind of pop-up for racial equity hasn't been sort of piloted before, somewhat surprisingly, given how, again, widespread the problem is in the United States, but it appears to be working, right? And so we're going to keep it going at least until we've fully redressed the inequity we documented. And that's really important for reaching closure. So you can see here, this is kind of a schematic of how we're working with the Wisdom Council at the bottom of the graph, where we work with them through each element of acknowledgement, redress, and closure. We haven't gotten to closure yet, but the idea is we want to fully redress the inequity we documented, and we want to ensure there's a process that everyone agrees, including community representatives, that this won't happen again, right? Or that it will be monitored such that we'll know if this problem is creeping up again, and we'll be able to address it right away. And so that's kind of the model and how that feedback loop works with community members, to acknowledge redress and work towards closure. Maybe closure isn't something we can so easily get to, right? Because it sort of implies that, you've rebuilt that trust. And I think we certainly have a long way to go. But I think this sort of repair-based or restorative justice model has the potential to get to both problems at once, fixing the inequities that we're documenting, and also hopefully rebuilding trust with understandably mistrustful community members. Just want to make a final point too here before we move into the discussion point of the session, that there's been a lot of pushback to this work, right? There's a lot of backlash, particularly in the last couple of years. It's been accelerating. There was a neo-Nazi group that came to our hospital. You can see here, Brigham and Women's Hospital kills whites. And so there was a huge sort of social media backlash, particularly targeting Dr. Michelle Morse, who's a Black woman who now is the first ever chief medical officer of New York City Department of Public Health and Mental Hygiene. She's gotten targeted, sort of dramatically more than myself as a white man. And so, we've seen this over and over again where Black women in particular in the U.S. who are working on racial equity and health have been targeted and received death threats and all sorts of racist threats. And so just to make the point that while our goal is ultimately, of course, fairness, right? Addressing unfairness, there are all sorts of groups and sort of interests to block this type of thing, right? To protect the kind of privilege that exists in healthcare in the U.S., right? And sort of recognizing this as a threat. And so just to make the point clear that backlash is fairly significant. This was a piece that was written by some of the health leaders from our hospital. And, of course, it hasn't stopped our work, right? We're still moving forward with this pilot. We're still meeting with our Community Wisdom Council, every other month to really push this work forward. And so, but I do want to make that part just known, just because, navigating this, and, there's probably some things we could have done differently, but I think inevitably, right, there are groups out there who are looking to, to smear racial equity work and misconstrue it in terms of what it's doing. And so just as an added point to mention. So I'll go ahead and stop there. Hopefully some of this is also relevant, certainly to the UK. I think some of these things are probably somewhat specific to the US, but I think there's probably some overlap as well. So happy to kind of clarify anything that wasn't clear, and field any sort of questions or discussion elements. Thanks.
Thank you so much. That was such an insightful session, and I've definitely taken some things away. I've got a couple of questions, but I'll hold off for now. I don't know if anyone in the chat, I've unmuted Mike, so if you do have a question, do please feel free to just unmute your mic and just kind of forward your question over. If you have any comments, please feel free to share comments as well. No? Okay. So my question is, I think data is so important because, like you quite rightfully said, that it shows that it's I think from me coming from someone that's within the global majority, oftentimes you share your experiences with people and they often, I guess the word is gaslight you to make you feel as though you're making it up. So data, definitely seeing that data definitely feels like, we're being validated. But my question is, how do we pull that data? Where do you start from in looking into that data and creating that data?
Yeah, great question. I think, there was a lot of organizing that happened in the hospital to kind of push this project forward, but none of it really would have been possible without the data because working in this kind of academic and medical environment, that's really what speaks to kind of leadership and to people to say like, hey, we have this problem and we did this study in such a way that we really could clarify what we're responsible for. So I think that's crucial, right? I think it would be great if folks just sort of at some point, we've kind of been exasperated at times being like, do we really have to do another study, right? We've this kind of pattern, we know it's there, so can we kind of just act now already, right? This is an urgent problem for our patients of color. What the key thing is that there's a big push to do, and I think that there's been some successes in our hospital and elsewhere, is to what we call disaggregate the data. So to make sure we are actually collecting data appropriately by race and ethnicity, right? By how people self-identify, right? Not based on providers, maybe snap judgment, right? In terms, and so trying to get better data in our system and then to have like sort of dashboards and mechanisms to actually make this readily available. So we actually had to like kind of like through a tricky backdoor means through connections got access to our financial team's data where they actually had all of this, but it wasn't readily available to researchers to actually analyze and look at. So it took a really long time to get that data. And again, so a lot of folks are not collecting and disaggregating data, but and I think for all sorts of different reasons, but I think the sort of consensus view is that's essential if we're going to be able to deeply understand these kind of problems. If we really are providing care differentially, we need to be able to track that in order to fix it, and to be ordered to be able to clarify the problem. So I think an initial move that's crucial is to disaggregate, to sort of push, but ask your health institutions, your local clinics, be like, are you guys tracking these kind of inequities? Because if they're not being tracked, right, that's the kind of no data, no problem, right? There's no problem to be found, right? And then sometimes it shows up in other data sets, not the health data sets. It's maybe looking at some other council data set that happens to be like, wow, we have this lifespan gap. It's really dramatic, right? How can we begin to understand what's driving an 18-year difference in life expectancy? There's a lot of stuff that needs to be tracked in order to sort of sort that out and develop the kind of interventions that can be impactful.
That is really good. Thank you. We've got a question from Sharon. It says, how did you engage impacted communities as a part of finding the solution?
Great question. Really important. So one of our community health clinics has a really robust racial justice group, and they've been working within community for a really long time. In one of what like our hospital calls our target neighborhoods, right? Boston is a very segregated city by race, ethnicity, and class. And so we went to them, to the Southern Jamaica Plain Health Center, and to the racial justice group and be like, listen, like we told them about the issue we found, and they're like, listen, we've been working with community members for years on health activism because we really wanted folks who were not so much, knowledgeable per se about these kind of problems, but we're working actively to address them, right? Have been involved in organizing and activism to address them or to address other social determinants of health, right? So we wanted, members of these communities who were, aware that these problems existed and who were already really motivated, right? And we pay them. So we pay them for their time, at the sort of same rate that clinicians, doctors get paid an hourly rate to do work. And we set up a model in which, right, the time that they bring, right, which is invaluable because it's not a perspective that we have within the hospital represented, right? That they really get a chance to, we bring them information about what the data shows, what we've been doing, and they really brainstorm ideas. And then we figure out ways to then, do the work, be like, how can we do something like this within the hospital, right? How can we create this kind of pop-up that reminds clinicians that we have this institutional racism? And so that's the kind of model we developed that try to like really gives them space to discuss their areas of expertise, but not sort of burden them with additional work and to compensate them fairly, right? And so a lot of the questions that we get from other hospital systems and hospitals is that, how did you work this out? Even like technically, how do you figure out how to pay people? Just for some reason, very complex to pay people who are not employees. But we felt like that was really important, that again, people were remunerated for their time in doing it. So that was kind of our process, because I think it is a tricky question of saying, like, who is representative of the community, right? There's no way to perfectly democratize that process or perfectly say this is the right representative, but that's why we wanted people with ultimately we decided folks with a track record of working on behalf of their communities to address these sorts of problems would be kind of the way that we felt was most impactful and really most challenging to our institution, because we really wanted to make sure that we had folks who were willing to be critical, right? Willing to be critical of the way these kind of institutions like ours operate.
That's really, I have one more question. So with this work that you've done, I think what we find in conversations that we've had here is that sometimes it's the people within the system that find it difficult to start or process change, right? Because if
Yeah.
it's work, if it's not broken, why fix, you know? So I guess my
Yeah.
question is, after all of this research, how did the clinicians respond to some of the work, and what were some of the steps that you took to kind of get them all on board?
Great question. So a lot of different, and actually both Michelle and I sort of through different models kind of did some work on sort of community organizing and training in community organizing in ways that I think people don't think of as being something you would do within a hospital, but we found to be very effective. So we did a number of different sort of key processes. One was, really just doing a sort of classic stakeholder analysis. Who were the folks in the hospital who, kind of were the gatekeepers or who controlled whether or not we could move forward with this? Setting up one-on-one meetings, discussing this personally, talking about the importance of it, presenting the data, group presentations to like all the emergency medicine physicians who were the ones who were kind of making these decisions, group presentations. We would send out surveys to get their feedback, and ultimately worked both with leadership and the sort of, physician groups to get buy-in over time. First, to really convince them, and there was a lot of pushback, in part because those of us who first recognized it were in one department, but a lot of the folks who were most directly involved were in another, and there was a lot of tension initially. So we made mistakes in terms of bringing some people in too late that we really learned from. But now, ultimately, a lot of those folks who were brought in late are really leading the work. So I think there's a lot of there's no shortcut around that kind of organizing and sort of, one-on-one group-based education, number of different strategies in order to sort of really impress upon folks that this is a big problem, and that, the values that they care about, right? Providing equal care, providing the best quality care for all their patients. Like, even if they are sort of like, well, I don't know if I'm like, you know, I don't really understand critical race theory, whatever. That's all fine. Being like, this is a basic question of fairness and how we're treating people. And I think really being able to speak to folks on the terms, right, that they understand and care about, in order to push the work forward. So definitely wasn't easy for all the reasons you mentioned in the question, right? There's a lot of resistance. But I think with a motivated group, right, you can find mechanisms, you can find sort of ways in, and you find your sort of insider champions to then help, continue to push that work forward.
Thank you. I'm Sharon, I saw that you had your hand up. I don't know if you want to just ask a question.
Hi, I did post a question in chat. So hopefully, how long before you think you'll start to see improved outcomes? And I entirely appreciate that, this is one factor of a very complex, multidisciplinary, multifactorial issue. But in terms of, those with cardiovascular concerns, improving kind of, the race equity and longevity of life for those with cardiovascular concerns. So what do you think? Do you have some kind of, our ambition is that within 5 years, that gap might be closed by 2, 3, 4 years?
That's such a good question. Certainly within our specific, it looks like we've been able to close the differential care gap within a couple of years. So looking preliminarily at the data, and I talked about not only I talked about the redress part. So we're actually sort of intentionally overcorrecting in some ways, right, to sort of compensate and pay back for that lost access and lost. But it took us a couple years probably to correct ultimately. And I think then in terms of outcomes, right, it's really a cascade, and thinking just sort of a causal chain. Right now, more folks are getting tied into outpatient care. They're getting on the medications they need. I think it will take, years, if not even, a generation to sort of see really significant improvements. What I will say in one study that I've been involved in too is that, ultimately a lot of the domain that will shift the kind of outcomes and the kind of life expectancy gaps that we're seeing are probably outside the purview of healthcare. So we've modeled the impact on reparations payments in a cohort of older adults. So I think the sort of average entry age is in the mid 50s. So, but looking at that, we basically what we showed was that sort of reparations payments that would eliminate the wealth gap, the racial wealth gap in the United States, would eliminate about 60% of the life expectancy gap between Black and white Americans. And if you actually account for education gaps and income gaps, monetary income gaps, then it eliminates the entire life expectancy gap. And so I think the most, I would love to say like within healthcare, we can do these things, we can control the main drivers. But I think we're such an unequal society in the U.S. and we know that wealth and income and education are so important and based on our modeling. But what I think is really encouraging about that is that's not even, starting in the most important formative years, when you're a child, when you're an infant, all of those important things that already start to determine, your health and well-being, is that even in older adults, where you're able to remove most of the life expectancy gap through, again, you can call them reparations payments, but just through, wealth redistribution, right? Whether through taxes or other means. And so I think it is, I think a very clear-eyed view of the problem shows that, certainly at least in the US, like we have to be working on creating a more equal society in policy ways that go beyond healthcare. And so even though a lot of my focus was on the kind of inequities that are in the wheelhouse or in the realm of health professionals in healthcare, at least from my best understanding of the data, is that, there's going to need to be more significant investments in communities where these inequities occur in ways that aren't necessarily explicitly linked to health, but they, creating more parks, creating more green space, right? There's a lot of studies now coming out on green space and how important that is for health, right? So if you think about, and again, like I don't know the specifics in Westminster or other, areas where you all are based, but there are definitely things like that, in terms of environmental impact and change that will have, data-driven, expectations of changes in terms of health.
That's really interesting. I mean, it's been interesting, kind of, I think I had more life in the US than perhaps in the UK, but the whole concept of biological weathering and that they're at weathering on race and, putting aside, class, social mobility, income, all the rest, and just that race weathering. So interesting, really interesting stuff.
Yeah, exactly. That embodiment. Yeah, I think that's such an important concept, Sharon, like the embodiment of how these injustices, the daily microaggressions, the daily sort of racism that people, I guess not to say that it's not, it's lesser forms of racism, but it has, right, through the cortisol, through all these other biological mechanisms. But I think, there's at least some evidence too that by taking away some of the worry, some of the strain, through things like working towards, wealth equality can have an effect even later in life is ultimately encouraging as well. Oh, cool. Good to know about the green spaces. Yeah, I'm not super familiar with that data, but I sort of just kind of tracking it from afar. I just seen there's really been a lot of studies over the last couple of years that really track, green space exposure with a number of different health outcomes. So that's great.
Thank you so much. I don't know if anyone has any questions. Oh, yeah, Yvonne. Are there health inequities with particular health conditions between Black and white that affect life expectancy?
Yeah, so in the US at least, almost every health condition is more in terms of sort of the overall prevalence, but also severity. The differences being white people have more suicide in the U.S. I think more mental health problems in the U.S. and potentially more drug and alcohol. But otherwise, all other conditions, heart, cancer, lung conditions, cardiovascular, cerebrovascular, brain, all of those are more for Black folks in the U.S. are more prevalent issues. They start younger and are more severe. So the inequities are really across the board. So if you think about the number, when you especially now that COVID has receded, cardiovascular and cancer being sort of the top two killers in the U.S. There are really dramatic inequities at every stage, right? Cancer screening, there's inequities, right, between Black and white, diagnosis, treatment, access to treatment, right? So there's all this different cascade that then leads to earlier mortality from cancer. So it's a good question. So we really see it really across the board, except in those few sort of examples where maybe the burden's a little higher in white Americans.
Okay, I just have a follow-up question to that.
Yeah.
So in your response, is there I guess, is there data or any evidence to show why that there's, um, I guess, a higher rate around like cancer and stuff within Black people? Is there any reasons as to why that is, or?
Yeah. So I think it's multiple. One uh is the environmental conditions that drive a lot of cancers, right? So take like colon cancer, right? It's very diet dependent. We know there's differences in diet. People, Black folks are more likely to live in food deserts, have less access to sort of nutritious, fresh fruits and vegetables, et cetera. So I think part of it is the inequities in the socioeconomic and availability around the food environment in the US, and what's available. And then all the way like to the things I mentioned, like, then the how early do you get diagnosed, right? If you're less likely to get your colon cancer screening at age 50, I think we just bumped it up to age 45, right? That means you're going to get diagnosed later, which means it's going to be more advanced, which means you're going to have worse health outcomes. So I think it's multiple. There's very little evidence that there's a genetic basis to some of these things. Like there it does show up from time to time, but certainly like with most cancers, right, there's no sort of genetic smoking gun. There are some like exceptions, but even then it's usually just one among a larger milieu. And I think the more we look into it, the more it's, again, even with cancer, right, it's these environmental factors and things that are really hard to tease apart even in studies, right? Like when you think about something as complex and as long, sort of day-to-day basis, your diet, to try to tease that out from a genetic predisposition. But I think in general, over the last couple of decades, there's been a receding from this idea that this sort of genomic understanding of biology was going to sort of lead to these dramatic sort of victories against cancer, because it just doesn't explain enough of the variation. And certainly in the US, right, it doesn't explain the sort of genetic variability that exists really across racial groups.
Okay, great. Thank you so much. You only have
Yeah.
3 minutes left. Yeah, thank you so much. This was really, really good, very
Awesome.
thought-provoking, and a lot to take away. Sharon says fab session, really interesting. Thank you so much for your time.